All right. So, starting with fibromyalgia and other neuropathies, we kind of talked about this during pain management a little bit, but I want to just revisit it because it's sort of its own subset. It seems to be a really common problem that people seem to be presenting with. And whether it's fibromyalgia or diabetic neuropathy, post-herpetic neuralgia, those are maybe more of the standard neuropathic related ones, but there's a lot of pain syndromes that seem to fall into no man's land too. You end up treating them sort of like either, depending on what the source might be, or you might be suspecting, you might have no idea. So you might end up treating it kind of like a neuropathic pain, or at least trying some of the neuropathic agents. The good news is most of the agents are relatively non-addictive, and you don't have the same concerns and restrictions and everything around like prescribing opioids. So from chronic pain management, it's a little bit of a different ball game. However, there are still some things to consider. So and really, when we're talking about these different pain syndromes, fibromyalgia, diabetic neuropathy, it's really all the same thing, same treatment. It doesn't really differ based on the specific diagnosis. So with antidepressants, there are a couple that seem to work in this category, and we're going to, of course, cover these more so. But tricyclic antidepressants are a good example of antidepressants that aren't really used that much anymore for depression. However, we do actually use them quite a bit for other things. So they're kind of sedating, so they use them for sleep management sometimes. But neuropathic pain has become a primary role of their, their skills as a drug. They work on a number of different mechanisms. So, like if you look at the current set of antidepressants, they mostly block serotonin reuptake, and we'll get into all that in a couple weeks here. But tricyclics work on both serotonin and norepinephrine reuptake, and so do these other newer antidepressants, duloxetine and venlafaxine. So really the key seems to be some sort of a combination between serotonin and norepinephrine reuptake inhibition, meaning you have more of those neurotransmitters present at synaptical junctions in the central nervous system. And while that seems to work well for depression, it also seems to have some sort of effect on neuropathic pain too. So the mechanisms behind it aren't totally well understood, but I know that duloxetine specifically has been used not only for neuropathic pain, but they've also been trialing it in small groups in osteoarthritis, things that you wouldn't necessarily expect it to work. It has been shown to be somewhat beneficial. So it's kind of interesting how that pain is probably much more complicated than we've traditionally thought about it. As we get more into some of these central nervous system related agents that seem to be having some sort of peripheral effects in the nervous system, we just don't really understand where. Is it having an effect upstream that's helping downstream effects? Is it working peripherally? Those are all good questions. We don't fully know. Those are sort of the early ones, and the antidepressants are nice to use because they're relatively, well, tricyclic antidepressants can be sedating, but if you give them at bedtime, people should be able to tolerate them okay. The SNRIs are quite well tolerated overall. They don't have a lot of side effects. Again, we'll get into much more of that in the next week here. Anti-epileptic drugs, I touched on these two last week, but the pregabalin and gabapentin, again, not really used much for their epilepsy effects. However, they are technically AEDs and could be used as adjuncts for partial seizures. And they really are used primarily. This is one of their main areas of use and why they're such popular drugs, both Lyrica and Neurontin. Again, Lyrica is a controlled substance. Neurontin is not, but may be in the future. Valproic acid has some evidence, but it's a little bit more mixed, so it's considered more of a second-line option. Other things we can try, of course, you can try any other type of pain management strategy. So ultimately, you could give somebody opioids. Of course, we want to avoid doing that as long as possible, just like with any pain management strategy. Muscle relaxants can work too. Specifically, cyclobenzaprine has been shown to have some advantages in fibromyalgia patients. And then IV ketamine is something they've been trialing in inpatients for people with really severe pain to see if that helps too. So again, ketamine is kind of one of those older drugs that people are using for a lot of things now, trying to find some better use for it. And this is one of the areas people have trialed it. And then topical ones. Remember, never forget about your topical options for any type of pain. And lidocaine patches can work really well for this. So topical lidocaine patches can numb and decrease the action potential or ability of nerve endings to have an action potential. So you're numbing the area locally pretty much. And it can be really nice for like areas of post-herpetic neuralgia where you can apply up to 3 of these big patches. And they're pretty decent sized patches, and you can cut them into different shapes so you can get them like around a weird area of the body. So that can be really helpful for patients too. It's a little bit inconvenient because you have to apply them every day, but they do tend to work pretty well from my experience talking to patients. Okay, next, restless leg syndrome. Really kind of a newer disease, if we want to call it newer. It's been around for a little bit, but I think there's been a lot of drugs that have been moved into this category of treating RLS. So really it comes down to an overwhelming urge to move your legs. And I don't think it's like you can't sit still, because like I like to bounce my legs a lot when I sit. I don't think I have RLS. So people should maybe differentiate that from actually like a neurologic disease that has association with unpleasant sensations. So there's some sort of like almost like a nerve pain type syndrome where you have some sort of pins and needles sensation, or if you aren't moving your legs, something's physically hurting. Significant leg movement during sleep is another thing that involuntary leg movement, I should say. Impaired daytime functioning, diminished sleep quality can be side effects of this issue. It is associated with iron deficiency, so if your serum ferritin is low, you could consider supplementing that. Otherwise, there's a lot of non-pharmaceutical options that have been shown to help mental activity during downtime. So keeping like playing computer games or something like that. It's almost like the concept of Parkinson's disease, where you keep some sort of a reward system going, and the dopamine effects might have some sort of positive impact on the RLS symptoms. Regular exercise, reduced caffeine intake, and then relief of symptoms. So walking, cycling, massages, hot tubs have all been shown to help sometimes. If those aren't working, you can try medication options. So dopamine agonists are the first line for most patients, and we're using pretty low doses compared to Parkinson's disease. And both pramipexole and ropinirole are both equally effective. There's no one that's better than the other, so either one would be fine to use. Second option would be gabapentin or pregabalin. And I shouldn't necessarily say first line or second line here. It's sort of a mixed bag. You don't necessarily have to pick one over the other. But I think this is generally what's been more studied and what's more commonly used. But you could definitely try gabapentin first if you wanted to. Especially if the patient has already impulsive tendencies, like we talked about, that having maybe some impact on that underlying impulsive or compulsive behavior that might be existing in a patient already. We don't necessarily want to evoke more of that. And then if the patient has underlying anxiety, probably a better option too. These can have a little bit of an anxiety impact on that specific disease type as well. There's a medication called Horizont, which I just put on here. It's a specific gabapentin brand name. Yes, question.
So just like with people abusing gabapentin, doesn't you say like you thought maybe eventually that would come?
Yeah, people think people are abusing it.
Okay. So
I don't know if I'm convinced fully, because I don't know really what effects you'd get off it, but people will try and abuse everything. So I don't know. That'd be a good like internet research thing to try and see if you can find some some. I've never actually looked it up what people try and get high off of it for, or even how they do it. But yeah, I don't know. But there is this extended release formulation. Gabapentin's usually like a 3 times a day, so is Lyrica. They're both TID dosed. So this medication Horizont is a brand name. I've never seen it used, but specifically indicated for RLS only. So gabapentin does have some studies and indications in that area. Carbidopa levodopa has been used as well in small doses and usually at bedtime only. So we're giving like an extended release maybe dose of something low overnight so that you're decreasing those sudden urges while people are sleeping. That seems to be helpful too. Again, thinking about really low doses compared to what we'd use in Parkinson's disease. And there's no real cure for this. Once people develop it, they seem to have it. So it's really only symptom management at this point. Maybe people can incorporate some of those lifestyle things and figure out a way to mitigate the symptoms better. But for the most part, once they develop it, that's it for them. All right, Bell's palsy is kind of an odd thing that I've actually seen quite a bit, but it's acute facial paralysis of not really a well-known cause. Most people think it's likely due to herpes simplex or zoster activation. So if you have a patient who has a history of zoster or simplex, that's maybe a key as to what might be causing it, but it doesn't really matter because you don't necessarily need that component either. You can have Bell's palsy without that. So it's a sudden onset of unilateral facial paralysis, which, as you imagine, could be kind of scary to see on somebody because you think you're having a stroke, but in fact they aren't, fortunately. The outcomes are pretty good, but severity of clinical presentation can affect it, but usually people recover within a few weeks of onset, and it's fully recoverable. If somebody has a one-time occurrence, you have a 7 to 15% chance of a second one, but the third or fourth attack is a much lower percent. So people might get 1 or 2 attacks, but after that it goes down quite a bit. And pregnancy risk is a big risk factor for this. It's increased risk, and then family history of Bell's palsy is also a risk. Treatments with steroids primarily is the go-to. That's the best studied treatment. So usually within 3 days of symptom onset, you want to start a steroid. And within 3 days is when this was studied. So when they looked at what the evidence is, it was started early in the Bell's palsy presentation. Now, most people, if they have suddenly like half their face is drooping, they probably aren't going to hang out for a week and then go to the ER, but you never know. But I think the evidence would say that maybe if you start it later, you don't necessarily get as good of a benefit from the drug, but that doesn't necessarily mean you wouldn't treat. So just want to give that caveat that that's the recommended, that you want to start it earlier. That's where the evidence says you get better results. And it's pretty high dose prednisone. It's like kind of like an asthma burst, but a little higher even. Prednisone, 60 to 80 milligram per day for 7 days. And then antiviral is the other component, which doesn't have good evidence. So basically, you want to look at your clinical presentation. If it's high grade, there's a lot of gradients of Bell's palsy that I'm not going to get into for diagnosing it. Basically, if it's high, if it looks pretty profound as far as their lack of ability to move part of their face, and maybe they have a history of a viral illness like a herpes zoster or herpes simplex infection in the past, then you might want to consider adding valsiclovir. However, the evidence is pretty unimpressive. Steroid evidence is pretty solid. I get this question a lot from my providers, like, what do I do for Bell's palsy? I know it's glucocorticoids and antivirals, but I know one of them is recommended, the other one's kind of wishy-washy. Corticosteroids are recommended, antivirals are wishy-washy. But valsiclovir, you can dose it 1,000 milligrams TID for a week. Then you'd give the prednisone on top of that. So you'd never just give valsiclovir unless a really odd situation where somebody was like adamantly opposed to steroids and you wanted to give them something. But usually the steroid is the primary backbone of the treatment, and then the antiviral would just be adding on to that if you want to. Narcolepsy. So narcolepsy, I just put this on here because I realized that I never talked about these drugs to any other classes. So you guys are the first one. They're kind of oddball drugs, and people do take them somewhat frequently, so I figure they're worth mentioning. Modafinil and armodafinil, they're essentially the same thing. One's an enantiomer, the other one. Provigil and Nuvigil are the brand names, and they're kind of an interesting medication. It's a non-amphetamine wakefulness promoting agent is what they call it. And we don't really know exactly what it does. People for a long time, at least when I was in pharmacy school, I had a professor call this legal cocaine, but really it doesn't make any sense because it doesn't act like cocaine. Actually, they've proven that it doesn't have the same neurotransmitter effects in the central nervous system that cocaine has. So it's really not a true statement if you hear that said. People might have some similar effects to it, I guess, maybe, that's like kind of a low dose of cocaine, I don't know, but it's something that isn't true. We don't really know the full mechanism of action for it. It's thought to have something to do with working on decreasing the inhibitory neurotransmission process using maybe GABA-mediated receptors, but we don't fully understand how it works. So it might also have some central alpha adrenergic activity, meaning that if it's a central alpha agonist like clonidine, you get some vasomotor outflow, slows things down a little bit, or maybe it blocks it. Again, we don't really know what's exactly happening. Peak effect 2 to 4 hours, duration 15 hours. It's pretty well tolerated. Most people have incidents of headaches, decreased appetite are the two common ones, and then there's some other rare things that we aren't totally concerned about. But it is I'll just put it out there that if somebody is having issues with wakefulness or narcolepsy, that's one of the therapies that is approved for that. They're both controlled substances, though, just for the record there. All right, so that's neuro. Just wanted to cover those quick little topics. Is there any questions on neuro in general? Review before we go into, yes?
I recently listened to the anesthetic lecture, and I guess I was just kind of confused overall what.
Yeah, okay, good question. So gases, I wouldn't spend a whole lot of time on gases because first of all, you guys are probably never going to work with anesthetic gases. I don't know if, you guys aren't CRNAs, so I just put it on there kind of for historical reference in case you work with surgery and want to know like how they put people under. But the anesthetics, the other ones like the IV stuff, there are a couple of questions like about propofol, about dexmedetomidine, so I would know generally like some advantages to them. It's pretty straightforward stuff, but the gases, don't worry too much about them. There's very little about them on the test. So I think there's like one question it asks you about some factors that would increase your requirement for gases. So I'll give you that one if you want to look into that, like what might be like increased cardiac output, those types of increased respiratory rates. So I think the answer is pretty obvious what I'm looking for in that one. But yeah, that's it. There's only like 3 questions on anesthetics on the exam, I think. So not a big part. All right, and then remember the supplements. So supplement questions, they're all pretty easy, I think. They're all stacked at the end of the exam, so don't be like, oh, I've got 7 questions left, because you should be able to blow through those last 7, I think. And it's really, again, a lot of stuff we've covered, basic things like, which vitamin is the first one to run out when somebody gets malnourished, what is vitamin D most useful for, which supplement or which herbal product has no evidence behind it, those types of questions. So, yes.
Can you talk about MAC a little bit?
Yeah, MAC is something I don't fully understand myself, but but it's so lower MAC percentages mean that it's a more concentrated, more potent agent. So I don't know what they're combining it with. So I don't know if a drug's a lower MAC, like nitric oxide. So if you're giving nitrous, you're giving 100% of it. Whereas I don't know if with the other ones they're more potent, so they're mixing it with like room air while they're giving it inhaled. So it's a lower percentage. I don't fully understand MAC, to be honest. So it's a weird concept. Yeah. If you want to, you can go on to be an anesthesiologist and learn all about it. So yeah.
So just real quick, we just had a lecture on epilepsy, and on her slides, topiramate is contraindicated in pregnancy.
Oh.
And on yours, you said it's okay. What would be the ambiguity or the gray area?
I don't know what the gray area is, because I feel like it was part of the studies that looked at retrospective use of anti-epileptics, and it was generally thought to be okay. I'll double check on that. But yeah, I think it's. I don't think it has any outright